Welcome. My name's Tim Weber. I'll be your moderator tonight for our webinar. We've got a great topic tonight, failed ankle fractures and how can we solve them or salvage them. I've got a great faculty, as you can see here. Brad Yu from Yale University and Matt Graves from Mississippi. You can see by the amount of titles underneath their names where the real meat is going to come from tonight. It won't be from me, but you get the right guys on the bus and the bus drives itself. So I really appreciate their help tonight. These are our financial disclosures, nothing too significant. So AONA is a nonprofit focusing on educating people for musculoskeletal injuries. We do not endorse any particular product or company. We're not going to be using any equipment tonight, so that's not relevant. Ankle fractures, only about 2%, or the number that's in the literature, only about 2% need undergo reoperation. I do think that that number is low, but that's the one that's in the literature. I think that given the volume of ankle fractures that are fixed, though, there's a large volume then that are going to end up with needing to have a redo procedure. Hopefully we can cover some of the reasons for those failures and solutions tonight. So basically we're going to talk briefly about some of the risk factors that lead to failure. We'll talk about why some of these things fail, and then if you have a better understanding of why it fails, maybe the solutions will be a little more obvious then. This is the agenda slide. However, we're really not going to follow this too closely. All of us will be presenting cases. This is going to be entirely case-based. I've got 2 slides in the beginning in an effort to not make it didactic. I think that when we're talking about some of these failures, so many of them are kind of unique unto themselves that if we can see more examples, we're probably going to learn a lot more, be armed with a lot more to solve problems. We will try to keep the 10 minutes question and answer at the end, but if nobody has questions, then maybe we'll do another case. So this first slide, I think, is super important. For me, everything goes back to anatomy, and I think that's true for most of us. These 3 pictures right here just really highlight or emphasize how congruent the ankle joint is and needs to be. You know, the pictures themselves just show how important it is when we're fixing fractures that we get it all right. Otherwise, we lose that congruity. And is that important? Well, you know, this is an old paper, but I'll tell you, 1 millimeter of displacement of the talus increases the contact forces or subjects us to increased risk for arthritis by 40%. And so I think the stakes are really high. Most of the ankle fractures are in young people where we don't have great solutions if it goes poorly. And so, yeah, I think that the risks are significant and the stakes are high for getting this right. I'm going to start out with the first case here, and then we'll have each of the faculty be presenting cases, and we're just going to try to get through as many as we can tonight. So this first one, a 17-year-old high school quarterback has this ended up with a Weber C type ankle fracture with a posterior malleolus. And this was how he was fixed by one of our local orthopedic surgeons. Afterwards, he felt a little uncomfortable about the posterior malleolus, and so he got a CT scan and sent the patient to us to have his posterior malleolus fixed, telling mom and dad that everything else looked good. And from my standpoint, I was pretty uncomfortable with that. I think that there's several things here that maybe small little things, but they all add up. So when I'm looking at this X-ray, the fibula doesn't look quite right. It looks angulated to me, both on the mortise view and on the lateral view. The ankle mortise itself looks widened. And I don't think this is necessarily the culprit, but the tight ropes that were used are way anterior here in the fibula. And we'll talk just a little bit more about that in a minute. Here's the CT scan. And when you look at this, you'll see that anterior tightrope, but you'll see how sort of comminuted this posterior malleolus is on the transverse cuts. And then if we look at it on the sagittal cuts, you'll see that the fixation doesn't really catch the posterior malleolus. It's a little superior to the posterior malleolus. The thing that this surgeon was worried about was that articular fragment that you saw that was kicked down there. And so
Tim, was he hurting more than the average patient that this doctor was used to seeing? Was there like some sort of telltale sign that prompted maybe some additional attention? Was it all primarily radiographic based?
It was all radiographic based.
Okay.
On why he was sent to us, you mean?
Yes.
Yeah. When you're talking to mom and dad have zero inclination that anything more is going to be done than just take that one fragment out and fix the posterior malleolus. And so
Tim,
I think that's always.
Yeah, I'm sorry. What surgical approaches were used in order to achieve that?
He's got a medial incision. He's got the incision for his fibular shaft, and then a couple small percutaneous incisions for the tightrope.
So they put the plate for the posterior malleolus through a medial incision. Is that right?
Yeah.
Yeah. Okay.
Yep. Any other thoughts with regards to this case before I move on?
I think you can also highlight the reduction quality of the fibula itself and its potential ramifications of the ankle mortise anatomy as well. This when on the lateral radiograph, maybe in the preceding slide, it just looks like there is potentially a little bit of apex posterior or some sort of rotational component through that comminuted area, which would raise an alert for a closer look.
As a positive, though, I'd say, Tim, this shows a great deal of effort. I mean, he was really trying to fix all the different problems that were present, and or the surgeon was trying to, excuse me. And I think it shows a great deal of effort trying to get things right. It just isn't quite there. Yeah.
I couldn't agree more. I mean, great deal of effort, and but at the same time, he's 17 years old, and
yep.
I think the other thing that's interesting about this one is, the deformity as we get farther away from the ankle joint, the deformity of the fibula gets maximized or gets amplified. It's kind of like, if you've got a small angulation at, the tibia just above the ankle, the mechanical axis doesn't get changed much. But if that same amount of deformity in the proximal tibia, your mechanical axis is off by quite a bit. And so this being more proximal, I think amplified the deformity at the ankle. But
one of the things that's interesting interesting to me is the axial CT scan cut and the reduction of the syndesmosis. I mean, the parameters that you look at radiographically, the tibiofibular clear space and overlap, even though we don't have the contralateral side, seem pretty reasonable. The talofibular joint seems pretty reasonable in terms of the reduction. But the CT scan made it appear as though the fibula was seated in a reasonable position in the incisura. Did I miss something there?
No, I would agree. I would agree with that. I think that the fibula is rotated some, and I'm not so sure whether. So just quickly, when you guys are reducing your syndesmosis, and I think I know the answer to this, but how do you go about doing that?
Got it. I can take that, Matt. It's a combination of a visual confirmation coupled with a radiographic evaluation, utilizing the contralateral side. One of the things that helps for me, at least for the rotation, is that kind of hemispherical radiographic silhouette that's at the end of the distal fibula. If you ever appreciate rotating that segment next time anybody in the audience does an ankle fracture, you'll see that that configuration changes in terms of its medial to lateral elliptical nature. And you can kind of judge the rotation based upon that. Then you can, of course, utilize the lateral radiograph to see the overlap of the posterior border of the fibula with respect to its relationship to the posterior malleolus. That will help to get you close in three-dimensional space. And then I think with visual confirmation, looking at the incisura, that's also similarly very helpful as well.
Yeah, so I'm typically using contralateral radiographs, trying to do all the things that Brad described. And then if I feel like I don't have it correct, I will look into it directly, but I do not look directly into the syndesmosis for every syndesmotic reduction.
Are you guys using clamps when you're reducing it, or digital pressure?
Yeah, so for me, it's digital pressure. I'm not using clamps. The application of the clamps and the points of the clamps on the fibula and the medial aspect of the ankle, the medial column, make a big difference in your reduction, as well as the force that you can create with the clamp. And that's all been shown in multiple studies. And so I feel much more comfortable using digital pressure and trying to recreate the contralateral side.
Yeah, same for here.
I think that that's one of the concerns from my standpoint with regards to the tightrope, is that the tightrope can sometimes act like a clamp, you know, depending on where it's put. If the clamp's put on the anterior aspect of the fibula, it's gonna you know, internally rotate that. If it's put on the posterior aspect, and I'm not here to sort of slam tightropes, but I think that you really have to be thoughtful when you're putting the tightrope in, if you're going to use them, to just make sure that you're centered and not rotating the fibula the same way as what we used to see when we used to use clamps for reducing the syndesmosis. Does that?
Can I make another point about just the radiographs? When I look at this my first impression of this radiograph when I saw it was that plate, it looks very centralized to me. And when you think about the typical configuration of a posterior malleolus, you got to think about, well, what is the goal of fixing this posterior malleolus? Are you trying to get articular congruity, or are you trying to reestablish ligamentous stability? And the posterior inferior tib fib ligament attaches to the posterior malleolus, provided that there's a specific configuration involving that posterolateral corner. And that plate needs to be buttressed appropriately. And this, to my eye, when I see this, I'm like, oh, wow, that looks really centralized. That looks almost medial. I wonder if they even captured it. And lo and behold, you beat us to the punch with that CT scan.
Yeah, and I think that, you know, because he was on a medial approach, you know, likely had the patient supine, was on a medial approach. This is as far over as he felt like he could get it, and was comfortable with doing that. And so I'll move forward here. So this is what we did. We started at the fibular shaft. It really was a little bit hard to control, you know, in defense of him. In my hands, required two plates, kind of almost 90-90 to really get the reduction right. Then we worked on the posterior malleolus, and then ultimately the syndesmosis. And this is what we ended up with.
Tim, the posterior malleolus, did you take out the small osteochondral fragmentation that was interposed, or did you try to reduce it, which can be very challenging, especially if you were going back through the medial approach? How did you address that?
I did a separate approach
Okay.
because I kind of wanted to be where I wanted to be,
Yeah.
which made it a little challenging given the fibular approach higher up. But we created enough skin bridge, I thought, that, and he was 17,
So you did a
so soft
posterolateral
tissues.
exposure distally?
Yep.
Yeah. Yeah. Figure.
Yep. Now,
Hey, Matt, can I ask a question?
I personally have almost zero success with rotating that fragment correctly.
Yep.
And not blocking my reduction.
Yep.
If that fragment isn't perfect, you can't get the rest of the fragment right. And so most of the time I end up having to take it out.
Yeah, those are typically incredibly small and hard to hold in place, especially while you're reducing the other fragment, which sits on top of them. So I completely agree with you. Weber wrote an article, not Hardy Weber, but another Weber wrote an article that's really nice about doing posterolateral and posteromedial exposures for this type of medial extension fracture of the posterior malleolus where there's separate osteochondral fragmentation. He called it a trimalleolar variant, and I think it was a good article and interesting, but I've had a hard time reproducing the reduction of those small osteochondral fragments. So often for me, they end up in the bucket. How about you, Brett?
Yeah, that was my question to you, Matt. For me, it's almost always I can't reduce it because it's just not going to be right.
Yeah.
Our vantage point is an indirect cortical read, looking at that axilla of the posterolateral portion of the posterior malleolus.
Yeah.
And then radiographic confirmation. So if you're not right, then you're going to be wrong, and that's an articular segment. So I was just going to ask you if you had any tips or tricks as to how you particularly get that osteochondral piece back into place, because I'm not good at it at all.
Yeah, I mean, the larger they are, the easier it is, as you know, but I agree completely with you. The smaller they are, you're really working with next to nothing. And even if you get them in the correct location, trying to stabilize them in that correct location when you put the other piece down on top of them is almost impossible. So I've struggled with that as well. I think most people do from others that I've talked to about it.
I see that I'm frozen on the screen. Is the audio coming through okay?
It is. Yeah, we can still hear you.
We hear you. Great.
Okay.
I like your hand up like that, though. It makes you look very powerful.
It does, doesn't it?
Yeah, you should just keep that.
Well, I don't really have control over it. I apologize to the crowd out there, but I'm in a hotel room doing this, and so I'm at the mercy of their Wi-Fi, which obviously isn't maybe working so great right now. But so here he is, initially post-op, and then with him healed and his syndesmotic screw out. And so for me in this situation, the take home are, that I think age of the patient and age of the injury, this was a lot easier. He's 2 weeks out. It's pretty easy to think that, you might be able to still see cortical reads and make this better. I think the farther the deformity is from the joint, the more displacement. I really think that some of that valgus is what was drawing the talus laterally. But I could be overreading that. And then I just, again, like we talked about with regards to the tightrope, I just think you have to be careful with it. So anything else to add there?
Tim, the medial side with the medial approach, I mean, you might have had a kind of a good look at the deltoid ligament, or at least the soft tissue capsule over there. I mean, was there any, how do you determine whether or not that needs to be repaired?
Yeah, I don't repair too many deltoids.
Okay.
For forever, I haven't repaired deltoids, and instability isn't my problem there. If you go back to those anatomy pictures, the congruity of the ankle joint creates a great deal of intrinsic stability there. I think that maybe just sewing the deltoid down is good enough, but I kind of believe that the deltoid probably has a specific point as to where it should be repaired to. And if you don't get that right, you can really create some stiffness. I redid an ankle just a week ago that they had fixed the deltoid. And I really think the fixed deltoid was the culprit of rotating the talus out of the mortise. It wasn't until we really freed up the deltoid on the medial side that we could get the talus back in again. So I don't fix a lot of deltoids. I don't know, maybe I'm too much of a dinosaur on that one.
There was also another thing that sometimes people ask about is there a particular position of the ankle that the ankle needs to be positioned in when you tension your fixation across the syndesmosis?
You know, it used to be that we always put it at 90 degrees, and I think that that's probably still a decent practice, but I don't think it's as important that we have to always put it at 90 degrees. You know, until that syndesmotic screw comes out, I do think that their ankle geometry, you know, how it opens when you dorsiflex will be abnormal until then. You guys do it differently?
My biggest symptom that I see in patients that have had static syndesmotic fixation is an inability to maximally dorsiflex their ankle. And the activity is usually limited with like stair climbing, like reciprocal stair climbing. And so I guess in my mind, I always try to reproduce it such that the ankle can at least get into as much dorsiflexion as possible without compromising the integrity of the stability of the ankle joint, just to potentially make that not be an issue.
I'm going to give over the control to Matt here and let him run through this next case because this one is his.
Yeah, sounds good. There were a number of other questions that I wasn't able to get to. So if you look in the chat box, there's some more that need to be answered, and hopefully we'll get to some of them here. So this is a 40-year-old male, status post open reduction of an ankle fracture dislocation. All right, so I wasn't the initial surgeon, but I know the initial surgeon. They initially had problems achieving a concentric ankle mortise, and they had problems getting to neutral dorsiflexion at the end of the surgical procedure. And they knew something was wrong, and so they asked me to look at it after the surgery to see if I could help figure out exactly what was going on. And so these are the initial injury films. You'll see this is a severe ankle fracture dislocation. There's not only significant osseous injury, but also significant capsular injury and ligamentous injury as well. These are the initial reduction films that you see on the right-hand side of the screen. And so we'll go to the next slide, and I'll show you some of the intraoperative work that was initially done. And so they first went to the medial side after the debridement. It was a transverse tension failure type medial wound. So they went to the medial side after the debridement, used a modified clamp and fixed the medial malleolus, but they noted that the medial clear space still seemed wide and that the talus didn't seem concentrically reduced at that point in the sagittal plane. And so they tried to revise that and use bicortical fixation, which you see there to the right-hand side of the screen. And they went ahead and fixed the fibula, knowing that something wasn't quite right. And this is how they ended up. So this was the end of the first surgery. I'm going to go to the postoperative films and ask a few questions after you've had a little bit of time to look at this. All right, so Tim, if you were going to critically assess the intraoperative films or these postoperative films, what would you say?
Yeah, close but not perfect, right? Yep. You know, the talus is shifted forward,
yeah,
which, you know, we don't see too often, but the talus will follow the fibula, and so when you see that, you know, from my standpoint, I like to, you know, I look up the fibula to see if I've angulated the fibula or apex posterior the fibula to drive the talus forward. And then on the mortise view there, it doesn't look concentric. You know, the fibula matches the talus perfectly, but it doesn't match on the medial side, and so there's got to be some rotational problem there, or at least it would appear that way.
Yeah, Brad, anything else that you're bothered by?
Not, I mean, nothing that hasn't been spoken already. I guess just to
Yep.
reemphasize the fact that the fibula follows, the talus follows the fibula, and there looks like an apex posterior angulation. So I would think that would be the first major issue that should be addressed.
Yeah. Would you guys do anything different before trying to take this patient back to surgery?
You like diagnostically?
Yeah, diagnostically. So I'll give you one of their primary concerns is they could not get his ankle to neutral no matter what they did. Now he had a tight gastroc on the contralateral side, but this was even more abnormal than what they were experiencing on the contralateral side. They just could not get him back up, and they couldn't figure out exactly why that was the case. So there's the medial transverse wound, and then they did a laterally based incision for the fibula and to fix the syndesmosis.
So does that plantar flexion deformity, did that change with the knee bent or extended?
It didn't. They just couldn't get it up no matter what they did. Something seemed to be wrong, and that was their primary concern. I mean, clearly there's some radiographic problems here, but they seem to be most concerned about the fact that they just couldn't get him to neutral.
Well, I'm embarrassed to say, but this is why this webinar is great, is because I probably wouldn't get any further imaging because in my mind, I can get a read on that posterior cortex of the fibula. And the fact that his talus is shoved forward would be what I would go into this thinking on why he's not dorsiflexing more. And I probably would end up getting my pants pulled down in the OR.
Yeah, I don't know that's the case. You may have been able to figure this out without any additional imaging. Have you guys had an experience where you were trying to reduce a fracture dislocation and you ran into this problem, or you were trying to do even a pilon and you ran into the problem where you could not get a reasonable reduction of the talus under the anatomic axis? Have y'all run into that yet?
Most days.
Yeah, sure. All the time.
So what are some of the things that have kept you from doing that in the past, you think?
Soft tissue intrusion is a big
Yeah.
one. And so, you have to actually look in the joint and actually sweep it clean. The younger patients, they tend to have more stout capsular tissue that gets sucked in and cause problems.
Yeah, for sure. So I'm always worried about soft tissue interpositions somewhere. So, this is what I saw when I was looking at the radiographs. I agree the talofibular joint looks remarkably congruent. The tibiofibular clear space and overlap don't look quite right. It looks too tight to me. And I think they clamped it aggressively, trying to make it more stable because they couldn't figure out what was happening. The fibula has apex posterior angulation. The talus is anteriorly translated. The congruence of the ankle joint isn't correct from that anterior translation. And so, I ordered a CT scan, and initially the CT scan was read as not much of a problem. And then I asked the musculoskeletal radiologist to look at it again based on what was found in the operating room with the lack of dorsiflexion. And interestingly, and I've had this happen more than once now, but I have this case documented, so I figured I would share it in case anybody else ran into this problem. What you see is a CT scan of both ankles. And on the left-hand side of the screen, you'll see a view above the level of the ankle joint, obviously, and you'll see an arrow that's pointing to a tendon. And on the right-hand side of the screen, you'll see the view at the syndesmotic level, and you'll see the groove for the posterior tibial tendon, which you see posterior medially there on that view. And these are purposefully soft tissue views instead of bone views. And you'll see the normal side, which is at the top of the screen to the right. You can see the tendons in the posterior medial aspect of the ankle. On the bottom part of the screen, which is the side that was fixed, you see there's an empty space there. Something's not right. It looks different. And so tracing the path of the tendons which come down to the ankle, because of the fracture dislocation, there was a tendon that became interposed behind the posterolateral corner, and that was the cause of the problem and the lack of the ability to dorsiflex the ankle. And so I thought it was an interesting case. I thought it would be worth showing. This is unfortunately, so I tried to post him quickly so that I could get back to him and take care of it. for psychosocial reasons, he didn't show up for quite some time. So we didn't get back to him until 2 months after that original surgery, which was really frustrating. But you'll see his lack of dorsiflexion there. We had him in the prone position because I made a surgical plan to go after the tendon that was interposed in the back portion of his ankle. And what you see here on the left-hand side of the screen is a further out view. On the right-hand side of the screen, you'll see a close-up. And you see the posterior tibial tendon, which is actually in a syndesmosis posterolaterally. And that's why they were unable to dorsiflex his ankle because it was entrapped. And so after we extricated that tendon, we were able to redo his fixation and try better to get a concentric mortise. But interestingly, and I think this has probably happened to all of us, if you have had somebody subluxed for a long period of time, it's incredibly difficult to get their talus back underneath their tibia in the correct position. And so in this case, even after we fixed things anatomically, we were stuck in the situation where his talus was still anteriorly extruded. And so it required an external fixation to posteriorly translate the talus underneath the anatomic axis in that surgery. And I kept that on for 6 weeks, and we were able to get significantly more dorsiflexion after we did that, obviously prior to external fixation, after fixation. And over time, he recovered some of his dorsiflexion, but you can see his ankle joint is not happy. I mean, even here at his 6-month follow-up, while his motion has improved with inversion, eversion, and dorsiflexion, plantar flexion, his ankle joint is not happy. So I thought this would be an interesting case to show in terms of one of the reasons why you can get a non-concentric reduction of the talus, but even more importantly, the inability to dorsiflex the talus into a neutral position. So I would encourage you all to, if you have irregular motion at the end of the surgery, something's wrong. And so a lot of our patients have gastroequinus, and checking the other side, as it is typically bilateral, is useful to know what their normal motion is likely to be. A lot of them come with pre-existing problems like pes planus, which lead to gastroequinus or associated with gastroequinus, which can lead to anterior talar translation problems and limited dorsiflexion, of course. But excuse me, I'm going to go back one. That definitely is something that you should think about: soft tissue problems associated with the surgery that you've done. Is there an interposed tendon? Is there a fracture malreduction? Is there a capsular injury that's in the joint? Is there a ligamentous injury even after you fix the bones anatomically, which are allowing the talus to translate and become non-anatomic? So beware of these problems. These are typically things you can fix intraoperatively if you see them happening, just by sweeping a freer along the posterior aspect of the tibia, which you could have easily done through that transverse medial wound, or even through, in this case, you could have done it through the lateral incision if you went around posterior some. So that's been really helpful to me. And I've had a couple of other cases with similar findings where we've been able to reduce things after we got the tendon out of the interposed position. So.
Great case, man.
It's a fascinating case. I'm going to go ahead and switch it over to Brad here.
Okay.
So that he can present this case.
Yep. So this is
one quick thing, Brad. I can't see the Q&As, I think, because we're using my screen to share.
Yes.
So if you guys could pay attention a little bit to the Q&A, and we'll knock off questions as we can. Is that cool?
I got it.
I'm the world's worst person here as a faculty member. So sorry, my screen's frozen. I can't see the Q&A.
Killing it.
Right.
Well, all we need, Tim, is your mind. You know, you got that, so we're good.
Yikes.
So this is a 44-year-old lady. She's heavy set, and she had a car accident, and she never had any problems before that she knew about. But because of her size, she has associated pes planus and a lot of acquired flat foot. But she has this injury, which I think everybody in the audience is relatively familiar with, high fibular fracture with some syndesmotic widening and medial injury, capsular injury, and lateral translation of the talus. Where is the thing is not, oh, here it is. And then this is her more comprehensive views of her lower extremity, demonstrating a wedge fracture involving the posterior shaft of the fibula. And that's kind of that. And then this is the CAT scan that we obtain. We have a general kind of algorithm at our institution where we image most ankle fractures with CT scans. How do you feel about that, Dr. Graves, Dr. Weber? Is that something that you commonly do? Are we like radiating these people too much here at Yale?
Go for it, Tim. I'm answering questions.
I would say no, unless it's just a standard ankle fracture. Now obviously standard can turn out to be something bigger. I think when you got a posterior malleolus involved or something a little bit more extensive, I think that a CT scan is reasonable. I did see a few weeks ago that one CT scan, like if you the recommended yearly allowance of radiation, one CT scan is about 30% of what a person can have during the year. And so as these things start mounting, you can hit the yearly dosage pretty quickly.
Yeah.
But I think with posterior malleoluses, I like having a CT scan.
Okay. So here's this particular patient's CT scan, and it was deemed by the staff that took care of this patient initially that posterior malleolus is a little too convoluted to really get fixation into. So the decision was made to utilize radiographic parameters in order to reduce the syndesmosis, as we had discussed earlier. There was the there was the decision that was made to not repair the fibula fracture, as this was deemed to be reduced out to length, so to speak. So the fracture at the syndesmosis level was stabilized temporarily with these Kirschner wires. And then ultimately the fixation was this, which you can see, just like the tightrope example, you can see that the implants are pretty anteriorly based, which would affect potentially an internal rotation moment on the syndesmosis, which in this particular instance might not necessarily be too deleterious to the patient's overall reduction. So at 8 weeks, the patient was told to walk, and this was the x-rays that the patient had at the time of her weight bearing. And you can see even with this simulated weight bearing film, she has a substantial amount of pes planus in her lower extremity, and she has a sizable size limb. So she kept walking on it, and she had a lot of pain, and she says that she can walk, but she didn't really know if this was normal amount of pain because she's never broken her ankle before. And she really kind of figured that this was normal. But after a period of time, she kind of crossed some sort of threshold in her mind. And she said, okay, well, I need to go see a doctor about this. So she came back to our clinic, and she came to see me for this particular problem. And these are the radiographs that we had obtained at that time, demonstrating some fatigue failure of the most cranial syndesmotic ligament, maybe some loosening of the central and distal syndesmotic, not ligament, but screws, and commensurate loss of reduction and lateral translation of the talus. And then potentially the patient also on physical examination had a lot of tenderness when I palpated her fibular shaft. And so we envision that this is a non-healing fibular shaft fracture as well. Any kind of imaging that anybody would potentially get for this patient, or any other concerns that maybe I haven't raised, Tim or Matt?
I probably would get a CT scan. I just kind of would like to see rotation, and where the fibula is sitting right now, and I would love to see what her normal side looks like too. We have a real hard time getting when we order a CT scan to put both ankles in the gantry so that we can see them side by side. We have a hard time getting them to do that here in Indianapolis, but on occasion when we actually get it, it's quite useful.
Well, why is that, Tim? It's the patient characteristics, their legs are too big to actually fit? Is that the issue?
No, it's the radiologist. They want to bill them for two separate CTs.
Okay.
They want to do them. They want to do them separately. They don't want to put them both in the gantry at the same time. They want to have two separate bills. Just being
Yeah.
honest and frank, sadly.
Yeah. Does it matter if the CT is a weight-bearing CT?
I don't have access to weight-bearing CT, so I don't know. I'm obviously I like weight-bearing X-rays and would I think weight-bearing CT would be very useful. But do you have it, Matt?
No, we're not using weight-bearing CTs right now either. I don't know that I would do it in a case like this, because I would want to try to reproduce whatever I was going to be able to achieve in the operating room. And so I know I'm not going to get weight-bearing views in the operating room really. So I would be more comfortable getting a non-weight-bearing CT for something like this. I think they're interesting, but we do not have access to them either.
Okay. So we did get a CAT scan, and we were fortunate enough to get the contralateral limb in the same picture. And I think you can clearly see the asymmetry present within the syndesmosis. And so the syndesmosis has failed, and we're confronted with a patient that has a flat foot. And I think that's actually very relevant for people to appreciate the hindfoot alignment, especially with syndesmotic injuries. At least in my experience, when the calcaneus goes into a lot of valgus, it puts a lot of lateral force against the fibula. It really stresses the syndesmosis of a fair degree, and potentially this is one of the reasons why the patient had her particular constellation of problems. So we identified pathology, and we consulted the patient about surgical revision in order to ameliorate her symptoms. And so we said that, hey, I think that your fibula is not healed, so let me treat that with a revision surgery, and then we need to revise your syndesmosis. And the question for her that she asked us was, well, are you going to do the same thing? Are you going to just put screws across my ankle joint and hope that it works? Because you're telling me my foot's flat and I'm, maybe on a larger side. Like, what's going to be different about this procedure that you can guarantee will work versus the other procedure that the prior doctor gave us? And I think that's a legitimate concern. So there are different types of syndesmotic fixation that we can affect on patients, and we'll talk about that in a few moments. So here are the contralateral X-rays looking at the morphology of the distal fibula. Again, that elliptical kind of radiographic silhouette that's at the end of the distal fibula, I think it's very valuable to assess rotation. And the translation of the fibula on the lateral radiograph is exquisitely important. What is really, really even more important is that you take the time to really get a very good lateral radiograph of the talus, because a couple of degrees change affects an apparent translation of the fibula with respect to the posterior malleolus by a few millimeters. And that actually is make or break it for these patients. So it's very important for you to be able to reproduce a very good lateral radiograph. We began with her fibula first. Granted, this was a non-healing fracture, so the fracture edges have resorbed, but we imagine that there would be some component of shortening that can be restored along the obliquity of this non-healing fracture line. And so we kind of went with that and lengthened her slightly utilizing the contralateral radiographs. And then we gave her a little stout fixation. We double stacked some tubular plates, and then we went for the syndesmosis. And for her, it was a combination of debriding the gutter, and then actually utilizing just a kind of like an anterior almost compression to help rotate the fibula back into the incisura appropriately, and then Kirschner wired in place. And then this was actually a technique that Dr. Weber had shared with us at one of our learning experiences at the AO. And what he taught me was that this implant, which is a simple T plate, has a dual function. So it has the ability to be a washer for syndesmotic fixation, but then in the event that the fixation was to fail, loosen, break, fatigue, there is still that additional check rein by that the 90-degree orientation of the plate hooking around the fibula to serve almost like a hand, like a hook that they use to pull people off the stage, to hold the fibula back into place and maintain the reduction, even though the syndesmotic fixation has failed. And I think that this is a very powerful way of holding this reduced, and that ultimately was the fixation that we gave the patient. If you can see that we've restored her anatomy. I believe that Tim has another example of a plated syndesmosis. Did you want to go through this, Tim?
Yeah, sure. Let me get the control back here. I guess it's let me control it anyway. Okay, so this guy, he's a very large gentleman, 350 pounds plus, had this pan-talar dislocation. I'm not going to go through the whole thing, but I guess there's a couple of things that I would say with regards to this. So his soft tissue was really bad on both sides. We ended up doing something percutaneously. You can criticize me for that. Then he ended up with, an infection and soft tissue, and several months pass before we can ever get back to try to do something. So he's got this widened syndesmosis by the time we were able to do it. And again, the plated syndesmosis with a T plate like this, I think works really well. You've got screws that are going anterior to posterior on the tibia, so they're perfectly resisting the syndesmosis opening up. And at the same time, you've got screws going from the fibula across into the tibia. But those screws, so in Brad's case, he already had somebody put 3 screws through there. There wasn't a whole lot of real estate to get good purchase. With this situation where you've got your anterior posterior screws, they're really the ones that are resisting the syndesmosis opening up, as opposed to the threads on the screws that are going transverse. And in my hands, this has been a really powerful form of fixation in people who, like Brad had, where there was multiple screw holes there. You might not be able to get new real estate. You don't necessarily have to put it through new real estate. You could use potentially one of the old screw holes if you had to. But then in the really big people, I think this is another good option for stabilizing the syndesmosis.
So
Thoughts?
guys, yeah, that's really cool. A common question that has come up, which I think goes along with empowering your fixation of the syndesmosis, is when is it necessary to fix a fibula fracture that is more of a shaft fracture as opposed to a lateral malleolus fracture? So I'm curious how you guys approach that problem. We've shown 2 examples now where we went after shaft fractures of the fibula with associated syndesmotic injuries. And there are reasons we do that, but I'm curious what you guys have to say about it.
Yeah, I guess for me, it's hard to get the syndesmosis perfect unless the shaft is perfect. Now, I've got an example right here on the screen in front of us where, the shaft isn't perfect. But several months out, we were scrambling, with poor soft tissue, and this guy's got a lot of issues going on with a pan-talar dislocation and on and on. I just think it's really hard to get the syndesmosis right when something upstream isn't right.
Yep. Brad, anything different?
Yeah, I would say the same thing. Fairly aggressive at restoring the length and alignment of the fibular diaphysis. I guess the question is what does the faculty do with like those fibular neck fractures that are involving kind of spongy bone, hard to reduce? It's in a kind of tiger territory to begin with. Do you think because of the sheer distance between the fibular neck and the lateral malleolus, do you think that we make a difference by reducing that fracture that has maybe shortened by a couple of millimeters?
Yeah, I'm personally not going after many fibular neck fractures, whereas I do go after, let's say, most of the fibular shaft fractures associated with syndesmotic injury. How about you, Tim?
Yeah, I don't go after, like if it's right up by the fibular head, I'm not going to go after that. But I do make a much more concerted effort to do an open reduction of the syndesmosis and make sure I'm seeing what I think I'm seeing on radiograph,
Yep.
you know, on fluoro, I make sure that I'm actually just looking at that to make sure that's right. And I think that the metaphysis heals much faster
Sure.
than what the shaft does. Like in Brad's case there, you're asking those, you know, those screws to hold for a long time, given, you know, because the shaft's going to take longer than the metaphysis to heal.
Yeah, I agree. Especially in morbidly obese patients like that, you really have to empower everything in order to try to get healing. So I thought that was a strong way to fix a syndesmosis initially, but it still wasn't enough.
I'm curious as to both of your guys' opinion on with regards to that 2-hole or 3-hole 1/3 tubular plate that a lot of people use for when they're fixing a syndesmosis. I struggle sometimes at understanding what the value is with that, unless it's osteoporotic, really osteoporotic. But then, you know, you're saying that it's going to fail because the screw head implodes into the fibula as opposed to the screws pulling out from the tibia, I guess. Do you guys find a lot of use for that 2-hole or 3-hole plate when you're fixing a syndesmosis?
Maybe, probably not. I mean, it's something that I commonly do just because I like to equivalently compress like over a larger surface area and maybe like minimize like chances for like iatrogenic fracture of the lateral cortex or something of that nature. But from a biomechanical standpoint, I don't think it necessarily, provided the lateral cortex is intact, I don't think it really gives you that much more.
Yeah, I mean, I agree with what Brad said.
All right. So take home points from this, and you can chime in here too, Brad. I just think with the plate, that type of plate fixation for the syndesmosis in larger patients, really big people, it's a good option in people who have had multiple drill holes, because it just gives you a little bit different failure mode. You're not so reliant on screw thread. Anything more, Brad?
I was going to ask, can I ask you, if you see a patient with like a lot of flat foot deformity, do you change the construct versus somebody that has more neutral hindfoot alignment? And what is that change for you?
Yeah, I wish I was smart enough to know when to do that. I may add a second syndesmotic screw, but I think that like I probably wouldn't go to this type of fixation. This is more of a salvage one for me. But I would probably leave my syndesmotic screws in longer, and I would maybe add a second one.
Okay.
I think we're hitting on a really important thing, and I'll go through this case and try to go through it a little bit quicker, because that's well. So this person had a trimalleolar ankle fracture. Are both of you guys taking your syndesmotic screws out when you're fixing the syndesmosis statically like this? And when do you take them out? Yes, and yes, no, and then months.
It's not an obligation. We don't always mandatorily remove the screws. It depends upon symptomatic, like restrictions of like, dorsiflexion, like I had mentioned earlier. And then I was always educated that the syndesmosis takes a very, very long time to heal, greater than like 3 months, for example. And so we try to keep our syndesmotic screws in for 9 months or so, at least. That's kind of the ballpark that I go for. But I'm curious to hear what others think they would do.
So if they break or are loose and not symptomatic, I don't take them out. The majority of the ones that don't, I do try to take out. I don't do it before 3 months. I usually combine it with a fascial recession of the gastroc, because they almost all have a tight gastroc as well. So I just do that at the same surgical intervention.
I'm usually taking mine out between 4 and 6 months, something in that range. So this person, we took her syndesmotic screw out, and then unfortunately, she widens. You know, she comes back to office. She's complaining of pain. In the office there, I do sort of a reverse stress, if you will. I squeeze the fibula back and feel like it is moving. And so this one was on me. You know, if you go back here into Brad's point here, she has a significant flat foot deformity on her lateral here. You know, and those are ones that, you know, I think that we should run our fixation longer, maybe more syndesmotic screw fixation in these people, because they're just loading, they're really excessively loading their fibulas. And so the way I salvage this, if you will, she's about 6 months out now, but is we went ahead and reduced the syndesmosis back to where it was, put in a static screw, a 4/0 cortical screw that's 4 cortices, but then I backed it up with a tightrope through the old hole, so that and I'm, you know, the plan is never to take this screw out. Once the screw breaks, I'm actually potentially giving her a little bit more longevity on fixation with the tightrope backing it up. What do you guys think about that?
Tell me your plan. So you've put the 4/0 screw in, you put the tightrope in to back it up. Are you planning on removing the 4/0 screw ever?
Nope.
Okay.
Not on her.
So you're expecting to have a little bit of loosening around the 4/0 screw, erosion of the bone around the 4/0 screw. Is that right?
I think it just gives us a longer period of time now for that syndesmosis to become solid.
Yeah. Yeah. I mean, I think it's a reasonable thought. I find it interesting that with a flat foot, she doesn't have a widened medial clear space or a deltoid, deep deltoid that's stretched out. She just had that late disruption of her syndesmosis. I'm definitely more aggressive with people with flat feet in going to the medial side and in trying to empower the syndesmosis for this reason. I would not have expected this to happen though, based on when you took out the syndesmotic screw. And I think it's a very reasonable thought in terms of trying to empower it for a longer period of time.
So here she is post-op, and then she's about, like I said, about 6 months now. And I actually weight bared her pretty early after the redo, thinking that I had a little bit of a backup too. And again, I think that so much of ankle redos are centered around the syndesmosis. I'm glad we were able to show a fair amount of cases relative to the syndesmosis that, you know, gave us, you know, maybe some different fixation options and just thoughts with regards to the syndesmosis. I've been taking my syndesmotic screws out because I just don't think that the, you know, the ankle mechanics are right until that screw comes out. And almost, you know, obviously this one opened up on me, but the majority of the time patients, even if they weren't symptomatic beforehand, are like, oh, I didn't understand that that's where it was coming from. And I feel so much better now.
Yeah. Agreed.
I think we're running short on time. Is there question and answers that we need to address quickly,
Yeah.
and then we'll.
Tim, there was one about when do you remove the T-plate, if ever, when you use it for stabilization of the syndesmosis?
On revision syndesmosis stuff, I just don't remove it. They beat me once, or they beat whoever once, not going to beat me again. So I leave the T-plate in.
Got it. There was another question regarding syndesmotic fusion. Were you actually trying to achieve a syndesmotic fusion in any of the revision cases?
I do not. I'm sure some of them auto fuse, but I'm not intentionally trying to do that. How about you, Brad?
I've only done it once, and I really try not to do it ever again, just because the irreversible change that you wreak upon the patient's ankle mechanics, it's done, and they're very symptomatic.
Yeah, I think the only time I've gone for that is when I was going for a tibia pro fibula. So not just secondary to an ankle problem, much bigger problem.
Any other questions?
There's one question about Aquinas. It was directed to you, Brad. I don't know if you saw that one.
Yeah, it was up at the top.
Yeah. What role does gastroc recession play in your
Yeah,
practice?
so it's a relatively simple procedure. The gastroc equinus is really prevalent. It's endemic in our population, and you just need to seek pathology and identify the problems, because it is a relatively low morbid procedure, at least in my philosophy is. And you can, the patient's asleep, and if you prompt them before and you tell them, hey, we may have to release this tendon, but they will improve your ankle motion, then I actually go for it. But usually it's kind of a pretty rare thing for me to release somebody's gastrocnemius tendon when we're doing the index procedure. It's usually when they come back with additional problems do we talk about doing those types of things.
Yeah, last question, Tim. And I think we didn't clearly explain the logic of using the combination of a tightrope with a solid screw. And I know this is happening not just on this webinar, but in other places as well. So talk through a little bit why you chose to do it that way, if you don't mind.
Yeah, sure. So ultimately, at some point, the static fixation of the syndesmosis that screw is gonna break. And I can't say, I can't time that. And so it may break at a time when the syndesmosis still needs more healing. So this just sort of provides fixation after the screw fails, to maintain the syndesmosis a little bit longer, but is still dynamic.
Yeah.
All right. Well, unfortunately, we've run out of time, and so it's too bad, because this next case was really cool. Do you want to just say, Matt, real quick, just go off the image there,
Yeah,
as
sure.
to what the problem was?
Yeah, so it's contralateral images that you see on the left-hand side of the screen versus the images from the case that we were doing on the right-hand side of the screen. You'll see that the joint looks fat, and this is with a neutral dorsiflexion injury. You'll find with bad capsular injuries and ligamentous injuries, your joint can look irregular when it's plantar flexed or allowed to be in a non-anatomic position. So this is a neutral dorsiflexion joint, and it still looks fat, so something's wrong. And this, in this case, the deltoid was interposed along the medial clear space, and it was making not just a little bit of a talar tilt, but it was also making the rest of the tibia-talar joint look fat. And so we went to the medial side, we removed the deltoid, we repaired the deltoid, and then everything went back to normal after we revised the syndesmosis. So it looks very different. You see there from what it was before compared to how it was after we extricated the deltoid and repaired it. So soft tissue interposition is a real thing. I'm more aggressive in repairing the deltoid than what you described, Tim. I may have some that I've repaired non-anatomically. In fact, I think most of them are probably somewhat non-anatomic, but I have not recognized one that was problematic in terms of rotation after that. So, yeah.
I got to come to Mississippi and learn how to do it.
Right. You're going to be really disappointed, I'm afraid.
All right. Well, thank you very much, faculty, Brad and Matt. Awesome job as always, and really appreciate your effort in putting these cases together and sort of talking us through it.
Thanks for having us.
I enjoyed it. It's
Yep.
fun.
Yeah.
Thanks, guys.